just taking out cuff, a little more on the anterior cuff. There's a little remnant there. It's
Sir, already. Okay, sir. Okay, sir. 1 second, sir. 1 second. I will send it. I will send you the Zoom link. No problem, sir. I will send you the Zoom link. Now only I will send, yes.
Metal.
Morning, Dr. Ayyappan.
Very good morning, sir. Thanks for joining, sir. You're in Goa, sir.
Tomorrow. Tomorrow I am going, but if you can take us through what you are doing, and
yes,
that will be nice.
Yes, sir. Sir, I did a debridement on this cadaver. So I started the posterior port, moving port, came to the anterior, and the cuff is quite good. There's some tear in this cuff. Then I came subacromial, and the acromion was pretty bad. So I took, and it was type, it was going all the way down. So I removed the significant portion of the acromion and made some space there. And took out the cuff. The cuff, the infraspinatus, the anterior remnant of the supra, some tissue there, and this is the
volume.
This is the superior labrum, and this was the glenoid, sir.
Okay.
And this is, so I put 2 anchors, one in the front and one behind.
Can we zoom in the outside camera? Outside.
Hi, Sandeep.
Hi, sir. Morning, sir. Morning. How are you, sir?
Bhai?
It's all good, sir. Thank you.
Okay, good.
So that is a anterior glenoid anchor. I do use a double loaded in case, because one comes off, I always have one backup. And second one is here, the posterior one. And now the footprint, sir. So the footprint is.
Which anchors were used, Dr. Ayyappan there?
Sir, all suture double loaded, sir.
Double loaded all suture. Okay. Any specific reason for that?
Sir, one, it is the glenoid, basically the glenoid. So we are very comfortable when you use a pancart and all that, and the purchase is pretty good. So it normally doesn't pull out at all. The pull out can be there when we actually doing a cortical debridement. So normally what I do is I do a cortical debridement after this, or I do make multiple punctures in the bone after this. So otherwise it holds very well. And I had actually one particular case where there is a metal anchor pull out. So I find it very good. Okay, this all sutures work very well.
Okay.
So this is the footprint. So this is a small dent which I made, and I'll put 2 anchors here, one here and one here.
Rajkumar.
Yes, Subramaniam. Good morning.
Good morning. Good morning. How are you?
God's grace, doing good, and wishing you all the luck. You are in the theater, Subra?
Yes, I am in OT only. Ayyappan, you are deliberately medializing, is it?
No, sir. It was I didn't do medialization. It was like this.
Okay.
So sometimes I do medialize, definitely, because, and I always try to put the anchor in the edge, sir, because the rest of find near the edge, and we have when the graft is coming, we would like to start the graft anchorage and the graft absorption from here to here. So normally I deliberately go up to around 5 millimeter, 1 centimeter maximum. I do go, and but here I have not done it, sir. Especially being a cadaver, I didn't want to debride it much because I didn't know the bone hold. Yes.
Okay.
Ayyappan.
Sir.
Any way to know beforehand the quality of the bone is good or bad, or any tips and tricks on table that you will use to ascertain that the quality of the bone in glenoid and head of humerus is okay?
Sir, normally when we take this, there's a awl is there, we can feel with the awl. So that is the only way we know. But again, normally I play little safe, but because I don't decorticate, then I put it toward the maximum bone thickness would be posteriorly. Here you wouldn't have much of a problem. Here the cortex is pretty good, posterior superior. Here the maximum, it is quite a bit weak in this area. That is anterior superior, anterior area weak. But again, in the biceps area, it is pretty good. But otherwise, preoperatively, the X-ray maybe, but still, it's we don't have anything to say that, yeah, this is we can judge it preoperatively. Difficult, sir. But I think we should expect in all older patients, especially lady patient, postmenopausal, I think we should definitely expect it, and when we go in. But
Dr. Ayappan, Dr. Rajkumar has asked a very specific question because there is no cuff on top of the femoral head.
Sir.
So automatically or by default, there are no forces getting transmitted there, and it's very important that the fixation is robust and adequate to hold your graft there.
Yes, sir.
Even in younger patients without a cuff, the bone is going to be very weak there.
Yes, it is, especially in the anterior. Here, it is always weak. Yes, sir.
Are you using a triple loaded anchor? Huh?
Yes, sir, triple loaded, because we can play with the graft. For the graft, we need to use sutures. That is, I'll take either the blue or black, anything. Remaining, we can use for suturing the remaining cuffs.
Okay.
Subra, any thoughts on what would be your thoughts on you seeing the red flags when you're putting all suture anchors on the head or the glenoid? Any particular way of pre-planning? Subra, Sandeep.
Sorry, ask the question again because
any red flags that you will look for while putting the anchors pre-op that you will know beforehand while you're putting all suture anchor on the glenoid and the head of the humerus?
In the MRI picture, you're asking. Huh?
No, any red flags?
So in the surgery, Dr. Subra, Dr. Surgery.
Essentially,
surgery.
Bone quality is something we want to know about. The bone quality is not excellent, then whatever you all suture anchor you want to use it. I don't use all suture anchor for these kind of procedures. Mostly we'll use either a peak anchor or a bio anchor.
If it comes out, what is the option, Dr. Subra?
I don't have
use a 5.5 mm peak anchor. If it comes out, what is the option left?
And
yeah, so we have a situation here because one, the bone quality is bad.
See, already here, if you see what Ayappan's bone quality, you see that one already is
yes.
Here I have only two choices. Sir. One, I have to take it posteriorly, or I will take metal.
So sometimes we can go right up to the other cortex and try to get some hold of it from there.
So either I put a new anchor here,
yes.
Otherwise, I will go with the metal here.
Take metal and go right up to the other cortex.
Yes. Okay. So
once you get some hold to the other cortex, you can stop there, not to pierce inside.
So it happened once, sir. What happened was, I had a case where it went all the way through and it came out to the posterior cortex.
It can happen. That's why I'm telling you need to be having a good tactile judgment.
Yes.
So when you're touching the other cortex, you should stop.
Everybody is not experienced.
Once it goes to other cortex, you cannot take it out. It's very difficult.
You cannot take it out.
Because you have to go from other end and it's a nightmare. Then your surgery will be like another extra 1 hour.
Live surgery, it happened once in Coimbatore. So
it happened? Huh?
Yeah, live surgery, it happened.
Okay. There is high chance of these things happening in live surgery. Normal surgery it won't happen. Live surgery it will happen.
Only time. After that, I never used a metal anchor. It's been 11 years. I never used a metal anchor.
Yeah, that's so. But I mean, the advantage for metal anchor is because it has got a sharp end. You know when you are touching the other cortex. But peak and bio, that also goes in, but not like as easy as metal anchor.
So this is the measurement probe. It's a flexible probe. So I'm just doing the measurement on the glenoid side.
Any tips for measurement, Dr. Subra?
One second.
Usually use your measuring gauge probe. There is also a Visinger rod available with the measuring gauge in that. You can actually use that Visinger rod to see from medial to lateral and also anterior to posterior. And make sure you do a good soft tissue clearance before you do that.
Yes.
Dr. Rajkumar, anything you want to add?
No, I think there are special probes as Ayyappan is showing. You can also use the regular probe with laser marks are there. So you can titrate according to the needs of the surgeon.
Okay. I
think,
will request
Ayyappan would be.
Sir.
Yes, go ahead, Hemant.
I would request the senior team members, whether does it make any difference with the position of the arm in respect to the measurements? Ayyappan, are you adding any coefficient?
Sir?
Are you adding any extra coefficient for the abduction of the arm?
No, sir. Okay. So basically around 45 degrees. That's it, sir. Otherwise, nothing.
No. If you measure the distance between the glenoid and the humeral head in 45 degrees on the neutral position, post-operatively patient is going to be neutral.
Doesn't matter, sir. So that's why even when you're fixing it,
Yeah.
the fixation would be so from 15 to 45 degrees is the ideal position of fixation. If you fix it
Okay.
in that, and definitely the repair should be able to take the tension, sir. Nothing happens. So
Okay. Great.
definitely in the 45 degrees we should fix it, because appropriate tension is required and can be achieved only from 15 to 45 degrees. And so, and even if you adduct it to 0, nothing happens. So I don't
Okay,
use
that's great.
abduction pillow. I don't use, because I believe that there should not be tension in the graft or in the repair.
Okay, I wanted to know because from 45 degrees, most of the time, sometimes to get a good elevation, we may cross 60 sometimes. So when under those circumstances, if you adduct the patient post-operatively, the measurement shouldn't vary and cut through shouldn't happen.
Yes, sir. Yes. So I think the measurement should be taken in the same position, like 45 degrees, and the graft should be put at 45 degrees. And then after that, I don't think there's a problem, sir.
Okay, nice of you.
Dr. Ayyappan, I'm from Kerala. I just want to add 2 questions. I'm not just familiar with this. So after putting the anchors, you start taking the measurements, and you add some relaxation extra 1 mm, 2 mm to this.
Yes. When it comes to the graft preparation, right now, what I did right now was there is the distance between the 2 anterior anchors is
Excuse me, some disturbance in voice. Yeah, somebody.
Rajkumar sir, disturbance. We can cut. Make it mute, Rajkumar sir.
Okay. So you put the medial anchors first, then the medial footprint anchor, then again go to the lateral, or the lateral you put on the end of the surgery.
Yes. Only after once you pass the graft and all that, you put the lateral road. So here I made the mesh. Once the anchors are passed, I made the measurement. The measurement between the anterior 2 anchors is 1 centimeter, and it's around 1.5 centimeter between these 2. I've kind of this is not ideal. I would like to have little more this way, but it is 1.5. So then I have to take the distance between these 2. The glenoid here.
So in the glenoid anchor, is there any fixed landmark, or you get the best bone purchase? What is the distance between the 2 anchors? It should be ideally.
It should be maximum height, but again, it should be on the superior surface rather than the anterior or posterior surface. So you can go from the coracoid, the base of the coracoid, and come maximum posteriorly.
Okay, you go beneath the labrum or from above the labrum also?
Here in this case, I have gone above the labrum.
So, Ayyappan, pardon my ignorance. What is the instrument that you are using to measure the?
So this is a flexible probe from measurement from, especially for SCR, from Arthrex.
Ah, right. Okay. Okay.
So it is very flexible. We can bend it.
Yes, yes, I can see that. It looks like very user friendly also.
So total 4 measurements you take, is it the between the glenoid anchors, between the footprint anchors, and from the glenoid to the anterior, from the glenoid to posterior, is it?
Correct. So correct. So here we got a 3 centimeter. So here I'll just repeat it again. The anterior, that is the anterior here. In the medial core, the distance between the two anchors around 1.5 centimeter. Here it is 1 centimeter. That is the gap between the two anchors. And so what I will do right now is I'll take 5 millimeter extra on this side, that is glenoid side, 1.5 centimeter extra on the footprint side, 5 millimeter anterior and posterior. So that's the plan now. Now we have everything in place. So now we'll go for the graph.
So the graph I have not taken now, isn't it? You're going to take it now. Is that correct?
I'll take the graph now, sir.
Okay. Okay.
On the glenoid, 5 mm extra means in the anteroposterior plane extra, is it?
I'll just show you.
Okay. Okay.
Can the cameraman show the external picture?
Can you see now?
Yeah.
No, but this, yeah, you can see it now.
So here it is 1.5 centimeter. Here it is 1 centimeter, and this is 3 centimeter. So now what I would like to have is I would like to have 5 millimeter extra here, 5 millimeter here, 1.5 centimeter extra here. So that means what 3 plus 2. 3 plus 2. That is the total length of the graph which I want. What is the width of the graph? What is the width of the graph? I should have 1.5 plus 1. That is, here it is maximum 1.5 plus 1. That is 2.5. Here this is the graphed anterior posterior which I want. So 5. So here it is. Length is 5 and this is 2.5.
Ayappa, what would be the thickness of the graft that you would normally expect?
Sir, it is ideally 8 millimeters. So because the ideal thickness which is proven by papers and Dr. Mihata is earlier it was 6 millimeter, now it is minimum of 8 millimeters, sir. So we can either double it or triple it, sir.
Why from 6 they have gone to 8 millimeters? Any particular reason?
But according to the mechanics in the humeral head depression is too less with the 6 millimeter. That is why earlier Arthrex used to have the Arthroflex patch. The patch was too thin, and there is the proximal migration, then stretchability of a thinner graft. If you are using a thinner graft, the side-to-side repair is also important. So when you do the side-to-side repair, if you're using a thicker graft, then we need to use only a posterior side-to-side, that is posterior cuff to the graft. Using a very thin graft, we have to use posterior side-to-side plus the posterior side-to-side. So one thickness, stability superiorly as well as horizontally.
I think it's almost always you have to double the graft.
Yes, sir.
Single layer doesn't give that thickness at all.
Yes, sir.
Once I did with fiber tape augmentation in the graft because I could not get that good thickness. So after I did 2 layers and then I did fiber tape augmentation. And which level are you taking the graft, Ayappan?
Here, the patient was in lateral position, and here I'm taking a midline incision over the GT. So greater trochanter. So here the ideal way to start is like normally one hand, that is one hand with
find out.
And at least
some disturbance is coming, sir. Can anyone mute, sir, please? So actually lateral position, and is it from the GT 1 finger breadth? Is it?
So this is the upper portion of. I marked the GT, upper portion of GT here. So am I visible? Yeah. Yeah. So this upper portion of GT, one hand width above and 2 hand widths below. This should give us the ideal graft excision side, harvesting side. This is the best. So here
So GT is in the center, is it?
GT is in the center. So I have marked the GT. So this GT is somewhere here. So here it is. I've gone normally in a normal tissue, we can just take a once the fat is cut, we can take a pad and just elevate it. Here I'm to just scale it off the TFL. Hopefully I'm yeah. So it is slowly coming up. I'll take a more liberal incision here.
So as per the predetermined dimensions, we are taking this graph, that is 3 plus 2. Is it extra? Is it?
Correct. So that is now what is my measurement? It is 5 into 2.5. So that means I should have at least a 10 centimeter long graft with a 2.5 width.
Can the outer camera stay still and show what you are doing, Ayyappan?
So yeah. So
now ask him to stay here still.
Yes, sir.
And not to move.
Is it 2.5 centimeters? Is the uniform from the glenoid to glenoid anchor and the foot anterior and posterior anchor medially? It's always like that, or it happens?
The distance between the medial row anchors is 1.5 centimeter. So we need 5 millimeter anterior, 5 millimeter posterior extra. That is 1.5 plus 1, 2.5.
Mm-hmm. That is the same in the medial and the lateral, is it?
Yeah, that is fine, because see, when you take the graph, you need the widest, isn't it?
Because we have put the anchors a bit wide and the dimensions has gone up, we can titrate accordingly, is it?
We should. This is basically according to the anchor position.
You need 2 centimeter extra medial laterally and 1 centimeter extra anteroposteriorly. Is that correct?
Sir. Yes, sir. Yes, sir.
5 by 2.5.
Yes, sir.
Okay.
Yeah. And are you taking double length now? 10 by 5.
So here I am taking 10 into 2.5, or at least 10 into 3. So here, so the thickness of graft normally we get in this above the GT area where the G max comes and attaches. So you should not be taking 2 down. Here in the upper portion is thicker graft, especially with the G max the abductor attachments and the G max attachments coming in. So this looks good. So I can start from here. This is the upper portion and this is 10. I don't mind going little more. I can trim it little later. I'll go up to 13 because in the cadaver, I don't mind a longer dissection. So that's fine.
When you take 10, it will be, the GT will be exactly in the middle. What is?
No. Okay. So that's why it is like upper third, 2/3. Upper 1/3. So here I'll go up to 3.5 and I can trim it later. Yeah. Here I'm making the horizontal cut. The cut should be little. You have to be careful with the cut because here it is quite thin, and immediately it will go into the vastus. And there could be normally there will be some bleeders, especially the perforators will start coming in. So you can find a bleeder somewhere here in the anterior area. Here you can always find some perforators. So here that the 3 centimeter. Okay. You can definitely see that here the thickness is much better. The thickness in about the GT area is always better, and it's quite thick in that area. So preserving that is very important.
And when you do the closure of the fascia lata,
Sir.
you will be able to approximate, isn't it? The 2.5 centimeter is easy to approximate.
We are not supposed to, sir, when there are outcome studies, considering the pain quotient, how much is the pain when we do a facial lata closure along with the function, we are not supposed to we are not supposed to close it, sir. Yes, sir.
Otherwise, they will end up with ITB syndrome.
Yes, sir. And patients
They become tight ITB.
Yes, sir. Okay, the pain is supposed to be more in such patients.
Correct.
So here, so I don't close it now.
You differentiate it from the bursa. You take the bursa also, and you can later on remove it.
Yeah, see, in one patient of mine, I definitely had a recurrent bursal problem, bursitis. So now I always take out the bursa completely. Earlier, I used to, I was not bothered much about the bursa, but nowadays, okay, I take out the bursa, excise the bursa properly.
From the graft, is it?
Yes, yes, okay. And you should remove the, not only from the graft, from the, once you have removed the graft also.
From the GT area.
From the GT area. Normally it peels off in the actual patient, it will peel off properly. We don't have to struggle. Here it is quite adherent. So I have to.
Normally, you use diathermy only there, is it?
Sir?
You normally use diathermy, or you're just using here diathermy?
Diathermy, and just when you make the cut to the diathermy, normally it peels off very easily, sir. It will peel off very easily. We don't have to struggle at all. Knife is never required, so we can just we can just take it out. Here the tissue is quite thick. The graft is out. It is normally it peels off. Here it is quite a bit adherent. I have to take a little more tissue out to remove it. We'll come to the graft preparation now. Is it visible?
Yes. Ayyappan,
sir?
Are you able to hear?
Yes, yes, sir. Can hear, sir.
Okay. Now you will, if you go more proximal, you will have more of your gluteus inserting into the fascia. Right?
Yes, sir. Yes, sir.
So any difference you see when you harvest along with more proximal or little distal to the gluteus maximus insertion, sir, in your choice for the graft.
Sir, Gmax insertion actually gives a little more, that insertion area is quite thick. So it actually increases the thickness of the graft. So we don't want to go too much up, but definitely like one hand width up is ideal, sir. So there we get enough thickness, but we are not going too much proximal into the muscle bellies. So here, we remove the soft tissues. Here the bursa here and some muscle attachment was here. We are removing it.
So the medial anthroposid was 1.5 centimeter. We have taken 0.5, 0.5, one extra. Is it 2.5? Is it?
I've actually taken a little more. Now I'll trim it to get to my requirement. So I've taken, what the requirement, how much length should I need? I wanted 10 centimeter long and 2.5 centimeter wide. I've actually taken around 13 centimeters. Since it is a cadaver, I took it out more. And in other cases also, I do slightly more, maybe 11 or 12 centimeter I take. and instead of 2.5 centimeter, I'll take around 3.5 centimeters. So then we can trim it to, because it is better to take little more to be on the safer side. And then we trim it to our requirements. This fat and other tissue should go because they become necrotic in time. So we want the minimum of extra tissue. Only the pure facial atta should be there.
Should make sure that always the facial atta is there only, because you have to avoid other irritating tissues, is it? The muscle and
tissues have to
the this extra length actually where it actually gets accommodated, will it becomes lax? It should be tight between the ankles, is it?
Yeah, in between the anchors you want tightness, but okay, you want, where will you put the anchors? The anchors have to pass out through exactly these points. Those are the fixation points. So you want the extra length, or only then you can put the anchors. I mean, pass the sutures that way. This time, level. So good. So we have made the measurements now. Cut okay exactly where we want.
Essentially, you have taken a little longer than what we want, isn't it? Yeah?
Yes, sir. Yes, sir. Just to be on the safer
So
side.
that you can trim it
Yes,
out
sir.
and make it to the extent that we want.
Take a little longer. So now we'll double it, and we will suture with nylon, suture and nylon. We'll show you how it is done. Good.
Can the camera be focused on the graph, please?
What around?
So you have to stitch the graft on the three sides. Huh?
Yes, sir. So whichever the freeze, I mean the doubling side, you don't have to do. All the remaining sides you have to suture with 2-0 nylon, non-absorbables.
Okay.
And which side goes into the lateral side? Is it the double side or the sutured side?
See, it is, if you want minimum tension or friction when you go in. So you don't want too much of a, so I would definitely put the non-sutured side inside.
But
Is
there any reason you want to interrupt the suture, or?
Sir?
So is there any reason you wanted to interrupt the suture?
Yes, sir. So basically, whatever from Dr. Mihata, he was doing this, and I continued that, and I didn't find any reason for not to do otherwise.
What I found is if you put continuous, what happens is it cinches, the graft will cinch. You can prevent the cinching of the graft by doing this. So interrupt is better than doing continuous.
Any graft alternatives, Dr. Ayyappan?
Sorry, sir.
Any other graft alternatives? This looks a very big surgery.
No, sir, it is not a big surgery. Sir,
Not a big surgery. Do you have any commercial available patches?
Earlier, this Arthroflex patch used to be there, but they withdrawn it from the market. And right now, there's nothing available to my knowledge in India. Yes, sir. And so when Arthroflex patches, but the problem with this, when you look at the outcomes also, definitely the mechanics, thickness, stretchability, facial lateral is supposed to be much better than any other patches out there.
Allografts are available?
Yes, sir, but I've not seen any papers being this, or I don't have any experience, sir.
What size the nylon switches are putting? What size nylons?
20 nylon.
Hemant, all these are not freely available right now in India. Spacers. Balloon spacer is coming in.
Yes, balloon spacers
is coming in, but none of them are freely available right now. Right now, the choice we have is autograph only.
Autograph.
Sir, in Korea, they have used Tendo Eclipse. Other allografts have been used, and they have pretty good results also. I think maybe when our systems are better, we can definitely use it. And Tendo Eclipse is supposed to have good thickness. I've seen being used, but I don't have any experience with them.
Any graft side comorbidities?
Sir, one of the patients, so one is pain. So the pain scores is supposed to be lesser and patient outcomes are better when we don't suture the facial lateral back. That means the cut we don't suture there, we just do a subcutaneous and skin closure is better. Number two, even if we remove the entire bursa, because some patients with bursitis. I've had a patient with bursitis, but it subsided, but definitely some bursitis was there.
In the ideal clinical situation, we put the patient on the lateral side and we have the trolley, everything. So we should simultaneously keep the thigh draped, or you harvest the graft a bit larger, then you put the anchors and plan it and trim it accordingly.
I didn't get it. So the way I did it is, so I start with the scopy. I always keep it ready. You can always, when the lateral position, you can always keep it ready. Your lateral side of thigh, and if required, you go in and take it. And the requirement, I would be opening it up only after putting the anchors, doing the measurements, and then take it.
So anchors first, then the measurements, then the graft. Is it?
Yes.
Just for 10-15 minutes, I'll be back, okay?
Yes, sir. Yes, sir.
I'm just going to see one OPD and come, okay?
So we are going back into the scopy now. So here, next step is I have to arrange my sutures.
Narayan, I have one question before. I just joined late. What are what extra portals you use for putting the glenoid anchors?
You see, so here you can see the anchors here. So I start with the posterior port, which then the viewing port changes to a posterolateral. Then I have a here is a mid deltoid port, so which is like 5 centimeters below. I'll start from here and then put it. And here there's a near deltoid port which I have that is again in the midline. So that mostly I play around with this port. I have this port I put an extra anterior port for an anterior. You can see that anterior anchor. To get that access into the anterior anchor, I need definitely a little more anterior port. So sometimes like sometimes in some cases the cuff would be intact. Getting into the thing, you need a Nevised port. So you can keep changing. There's no specific port. Okay, you basically have to get your anchors right. So you can switch the port the way you want.
First, you want to start putting the glenoid anchors into the graft, is it?
No, okay. So first, okay. Next thing what I'm going to do is I'm going to make some future passes with my and keep my remaining remnant cuff ready. Which I'm going to do right now. Okay. This is my anterior middle row. So I've taken the whites there. I'm going to take the scorpion, take whites in the anterior cuff. The integration of the remaining cuff is the key to your success. Okay, how much of a graft you put in, it will not help. So here, this appropriate suture passes are very important.
So we have a triple loaded anchor, and you take 2 bites from the remnant, is it?
So multiple bites. Okay, I'll just show you the remnants. Okay, so my whites are done. First. Level blade. Put a blade, please. Put it on. Take it off. So I already put lacquer away. So I didn't on. Switch it to. So whites, my whites from the first anti-triple load has passed. Next, I'm going for the blacks. So blacks. Here the blacks are, I'm going to take the blacks. Right. And again, this is again I'm going to pass it and keep it in the anterior cuff. Hand lift. Oh, great. ಹಿಂದೆ ತಗೋಣ ಇಲ್ಲಿ ತಗೋಣ lift and give traction. Right. Pretty soon. Lift hand little more. Lift into right. Got it. Right. Right, but right. Right. Come on, baby. Oh, man.
Do you pass all the 6 switches through the graft, or you keep it two unswitched, or?
Two unswitched because because I need for this right now. There's no graph passage, so I'm just passing the.
So you plan to pass only the 2 free switches to the graft, is it?
Absolutely. Absolutely. Pass passed. Okay.
Hello, Ayyappan. Good morning.
Hi. Good morning. Very good morning, bhai. So I was मैं क्या कर रहा था
I
like
it. So because there was active discussion going on, so I was just listening to it. So I just have one question. The graft patch is from the proximal part or distal part?
proximal part.
Okay, but can we harvest distal part as well?
Sorry, distal part, yes. So we can start like one hand width above the GT and
Okay.
2 hand widths below the GT.
Okay. No. Can we harvest from very close to the knee, distal femur, close to the distal femur?
Becomes little more thinner out there. So
Okay.
and we would like to harvest it from near the G max insertion. So because that is where it is actually the thickest. So
Okay. And you don't use cannulas much, right?
no, only one single cannula, 8 mm cannulas I've used right
When
now.
you are passing the graft.
Pull the black.
So in the posterior aspect also you are planning to do the same, triple loaded, 4 through the anchors, 2 free, is it?
So for the glenoid, which diameter anchor you have used?
Sorry, I didn't hear you.
Glenoid, which diameter anchor and which material anchor you have inserted?
I used a all switcher.
Okay.
Switcher double I've used.
Okay. And what about on the double loaded all switcher? And what about on the humeral head?
Humeral head, here you have used a peak. Normally, again, here also I used, you normally use all switcher, rotator cuff hangers. But
Okay.
here, wherever I've used one peak and one metal over here.
Okay, so all are double loaded or like triple loaded?
normally triple loaded. Here, okay, because I had to compromise. Here I put a double loaded, and here again I pulled out one. Okay, made it double loaded for easy understanding. Okay. Okay, now we go to the posterior angle. So now this is done. Okay, now I'm coming to the posterior. One second. Okay, one second.
Posterior also you do the same and keep two limbs free for the graft, is it?
Yes, because
And-
that you need to really hold on the infraspinatus there. See, the infraspinatus is the key. Your supra is gone. It is atrophied. There's no supra at all.
Okay.
Key to having a good result is the the force transmission from the infraspinatus.
Seemingly there is a good remnant of infraspinatus posterior, is it?
Yeah. All right. Let's see. ಯಾವುದು ಪಾಸ್ ಇಲ್ಲ ಓಕೆ ಇದು ಬರ್ಡ್ ಬಿ ಕೊಡಿ ಎಲ್ಲ ಅನಿಸುತ್ತೆ ನೋಡೋಣ ಅಲ್ಲಿ ನೋಡೋಣ ಅಲ್ಲಿ ಸಿಕ್ಕರೆ
The subscap should be intact. If you find a case where the subscap is not good or not healthy, you want to proceed with the SCR. What is your plan of action then?
Subscap should be repairable. That is a prerequisite to a SCR. The anterior posterior force couple should be intact. It should be at least a repairable force couple.
If it is not repairable, then you can do this SCR, is it?
No, you can't do a SCR. You need to do a muscle transfer. And you should go into other options.
Dr. Ayyappan, does the same principles work for the balloon?
Sir?
For the balloon?
Balloon. Yes, sir. I think balloon again was the inferior translation, centering of the head. Yeah, it works the same principles. Yes.
Okay. So there also subscap is important?
Yes, sir, definitely. So otherwise, okay, the only thing is the centerizes, but otherwise the subscap will not. If the subscap is not, you not have the force couples to go on.
Force couples to be there. Dr. Rajkumar, can you hear me? Dr. Rajkumar?
Okay, done. No?
Hello.
Yes, Hemant, I can hear you. Yes.
Any suggestions or any advice when there is no subscap? Can we do an reverse shoulder, or should we go for tendon transfers or any other options other than SCR?
Okay, on 1, 2, 3.
So we would like to stay in the present what Ayyappan is doing. Yes, there are options of tendon transfers when subscap is not great.
Okay.
But right now, to discuss that when this surgery is going on, it will be beyond the scope of what Ayyappan is doing. So we stay in the present, and then once he finishes, we can have discussion on what else we can do apart from SCR. Is that okay, Ayyappan and others in the group?
Nice of you.
Yeah.
So,
Okay.
so here what I'm taken is, sir, I've taken the glenoid anchors. That is the blue is the anterior glenoid anchor, and this is the anterior. I'm taking it out and I'm keeping it anteriorly. Now we'll mark it. I mark the anteriors so that I don't get confused. So mark it nicely and completely. This is the anterior and posterior. Both are in place. This is the posterior and this is the anterior.
Ayyappan, Dr. Ayyappan, what have you done with the double loaded anchor with the glenoid? Again, you pass through the cuff?
No, you should never pass through the cuff. Glenoid anchor should never be passed through the cuff. Why? Because if you're passing through the cuff, it gets stenodesis there, and then you don't have force transmission. The only thing then which will work is the tamponade effect and the inferior spacer effect. If you want this to work along with the force transmission, definitely you should not fix the cuff at this particular point. That is, in the glenoid side, you should never fix it.
So all the 4 switches from the glenoid should be passed through the graft, is it?
Yes. I am removing my extra wires. Sometimes what I do is I'll use it for a extra fixation, which is not planning in this case. Here you can clearly see the anterior glenoid, the posterior glenoid anchor here are the middle row anchors. I'm planning to keeping almost ready. Now, this is the anterior middle row. Mark.
So you have taken the 2 switches free switches from the medial row. You need only 2, is it?
Right. Right. Now here, so all the 4 switches are in place. Now we are good. So this is ready. Now I'm taking my 8mm camera out, cannula out. I have to make a bigger, wider incision to accommodate for the syringe. Here, this is our modified cannula.
So at present, we have free 2 switches anteriorly from the glenoid, free 2 switches posteriorly from the glenoid, and 2 each from the lateral side, is it?
Absolutely. Here, okay, so what I do is all the switches are in place. This is marked. This is marked. Okay, feed it. Feed everything. Everything. So I'm taking everything through a syringe cannula. So the syringe cannula which I've taken. You can see, hopefully, I guess. Yeah, hold this.
Ayyappan, I'm back. What is the current situation now?
So I've taken out, I've made 2 feature passes in the front. That means
Okay.
the sutures have been passed to the anterior cuff, to the posterior cuff, and then the remaining, that is the 2 glenoid sutures. This is the anterior.
Okay.
This is the anterior. This is the posterior.
Okay.
So
Okay.
all that can pass through. I'm going to pass it through a syringe cannula. So syringe cannula. Before that, I'm just opening it up nicely before the syringe goes in.
Okay. Okay.
Ayyappan, you take only the free switches through the syringe, and the bites taken from the cuff are parked anteriorly and posteriorly, is it?
Absolutely, absolutely.
Ayyappan,
Sir.
I think there is a lot of pre-planning needed. How you shuttle switchers on table, and
Yes,
you
sir.
need a good team to understand what is going on in your head.
Yes, sir. So a
How
team
long
is
that process has taken for you to have a team that gels well with you to help you out in this rather intriguing surgery that you're doing?
Sir, it took me 5 years, sir.
Absolutely, because Rajkumar, what you are telling is absolutely true. Because I think the most challenging aspect of this surgery is getting the sutures the right way and putting the graft through the cannula comfortably without any mismatching. And that is
Yes,
challenge.
sir. We took quite a bit of time because when we started doing, so we did a lot of planning. Now we have used to it.
And Ayyappan has openly said it took 5 years.
Yes, sir.
Definitely, there's a long learning curve there for this surgery.
No, sir. Actually, we started. We were able to do the first case took me a little time because but by the second case we were good. So the everything to this team to set up and to have everything smooth, it takes. Now my team knows what exactly I want. So where we are standing. So there's no confusions at all. But to get this team ready, it took 5 years. That's what NCC said. So I'm trying to put it this. What happened? This space, subacromial space is less. So here I've cut and put a 20cc syringe. It is not going in, but I have to manage with a 10cc. I'm trying to get a 10cc syringe to go in. 10 cc pulse. Just waiting for a 10 cc syringe to come in. Because this is a critical step. So here, how we pass the syringe, okay, how the sutures are there. One entanglement here is enough to take another half an hour out for us. So take your time to dissect, plan the sutures, mark the sutures, keep it anteriorly, posteriorly, and it should be fine. 10 cc. 10 cc syringe. So list jog and space jog. Bandu. Tolu. Should be enough. We are just making our cannula ready. We're almost done ready now. Right. Okay. Dilator. Right. Dilator. Dilator good. Let's go. Okay. Suture to it. Now the cannula is in place. Now I'll pass this. Take care of the suture. So here the clearing out the sutures are very important again. So we have to be very sure which is anterior, which is posterior. You have to be. So I go again. I cross check. I pull out independently each one. Right. Okay. The posterior coming in. The posterior. See, I've taken my posterior and parked my posterior again. Then blue anterior, blue posterior. Yeah. Now the sutures are in place. Now we'll come to the graft. So another thing when we do the graft preparation is, or passing the graft is, better to put a towel here so that it should be very sterile. We don't want any kind of infection. So keep it here, and then we keep the graft. See, Alice.
Ayyappan, if you can show how the sutures are being passed through that graft, if the outer picture can be made big, then it will be of some value to the viewers who are seeing. Yeah, that's great.
Yes.
Yeah.
One more, Alice. Okay. See, marking pen. So here passing in the right spot. So 5 millimeter from this. 1 centimeter. Yeah, so this is the mark point. So see here it is 5 mm. So it is 1 centimeter is the gap between the anchors, and here this is where when I pass, that is 5 millimeter from here, 5 millimeter from here. So now this is what I'm going to do is I'm going to 5 millimeter away.
This is the lateral one or the medial one? Medial one, is it?
This is the glenoid anchors.
Okay. 5 mm from the tip, is it?
Right. You must have seen the scorpion which we used. It is a multi-fire scorpion. It's a very beautiful instrument because at the same time you can pass two sutures. So it is very useful even in the cup. Your surgery number of passes are very fast. So here again, you can see it is in the
pass. Oh, you passed both the switches together 5 mm from the tip.
It is slightly past. One pass is done. Now the second pass, it is.
The outer camera person, if he can shoot from the top, it is nice, not from the side. Ayyappan.
We'll get it.
He can shoot it from the top.
Yes, sir. Yes, sir. Come closer.
Yeah, because your hand and some body is coming in the way of suturing.
Right. So now you are the anterior glenoid, posterior two glenoids. So we kept it ready.
Yes.
Now,
yes.
This from here our measurement is 3 centimeters. So we have to find the 3 centimeter mark. The 3 centimeter mark is somewhere here. And it should be 5 millimeter away from here. The space between this should be 1.5. Here the space is 1 centimeter. Here it is 1.5. Space between this 1.5. So one point is here. And the other point is here.
Ayyappan, I'm asking a little difficult question. Okay. So, our measurement has to be near accurate most of the time. How much mismatch is acceptable?
Yes, sir. Up to around 5. You can easily, because it doesn't, if it's too much of mismatch, either it becomes too tight and you'll have a graft failure, or too much laxity will not give the good function. So up to 5 millimeter here and there, it is okay with us. So I don't find much of a problem. 5 millimeters, sir.
Okay. Both side, anterior, posterior, medial, lateral. 5 mm.
Yes, yes, sir. We can have a play off. So much. Alice. So see, so this is the mark point. That is from here to here. It is from here to here. It is 3 centimeters, and 5 millimeters away, and the gap between these two is around 1.5. So what I'm going to do is here. What is my first fire? And here it will away next fire. That is the posterior middle row.
So all the switches are coming through different holes because it is a multi-fire instrument, is it?
Yes. See, I can pass it if a single needle. I can pass it through a single one, but I like the space in between, because what I'm going to do right now after passing is I'm going to do an anchoring there. I'll be doing a knotting there. At least I'll put 2-3 half hitches and fix it off. So I want the space. I like the space because that will give me anchoring points, because I can knot between these two. Right.
Ayyappan,
Sir?
You're doing good. Okay.
Thank you.
Anytime before you have passed your suture through the graft, has it slipped and fallen on the floor?
No, sir. Till now, no, sir. God's grace. Till now, nothing, sir. So we are very careful. And the tips to avoid that, normally what I do is, see this mop which is kept here. is I will actually clamp it with an Alice, hold it.
Yeah.
There will be 4 Alices here. 1, 2, 3, 4. There are big Alices in the cadaver, but otherwise I usually use 4 small Alices. Keep it clamped. So only after each suture is passed do I release that. So I try to keep it as much safe till now nothing has happened by God's grace, sir.
Yeah. So those are some tips and tricks that you should share, because you
Yes,
cannot keep those secrets with you and pass on. Correct?
No, sir.
You should share, because there is greater joy in giving than in only receiving.
Yes, sir.
What do you think, Ayappan?
Absolutely, sir. So I keep forgetting, sir. It is good that you are there, sir. You are, at least others would have forgotten. Sir, next, what we're doing is here next step what we do, these are the 2. You can see that how it is.
You're planning a double pulley?
Yes, I'm planning a double pulley. So here, but I will not tighten it too much. Here the pulley is just lightly put, and then the second knot again it is just, it's not tightening it too much, just kept it there. Second, third, switching the half hitch. Now it becomes tight. Switching the half hitch. Right. So that is
So that it doesn't compress the graft, so that is it.
Not compress the graft. Yes. So I'm cutting it off at the tip. So this is this is ready. So next, what I'll do is, Alice, here. Put together. So you can come this way. Pramod, come this way.
Ayappan, which are you using a cannula? Is it what is that?
It's a syringe, sir, 10 cc syringe.
Syringe, 20 ml syringe. Okay.
It's a vertically split 10 cc syringe, sir. Vertically split 10 cc syringe.
So you cut the one end of the syringe, that's right? Yeah.
The end of the syringe is cut, and we make a vertical split.
Okay.
You do the
Just want
same.
to know what are they using in Japan?
The same, sir. Okay, Dr. Mihal.
You also use the syringe only?
Absolutely, sir.
Right.
So he uses the same.
Because our canula's maximum diameter is 8 mm only, 8.5 we have.
Sir. Okay, so there is a
Not
passport cannula, 10 mm passport cannula is there, 12 mm cannula is there. So which
12.
can be 12 mm, and they have come out with a very interestingly, they come out with a graft holder also, which helps in holding like this and pass through the passport.
You do the same with the lateral row anchors, or also you won't just pass the graft to the medial double pulley? Yes.
No, see, you can see the lateral row. That is the middle row. The middle row is separate. 1, 2, 3, 4. The double pulley is not set. Okay.
The next is you want to deliver the graft inside, is it?
Yes. So delivering of the graft, see, you have to be very clear that it is. And lift it. Space kadame. Direct. Okay. E black section. Continue.
So you're trying to pass the free limbs of the medial glenoid anchor into the joint first, is it?
No, I'll be passing all together. I'll show you.
Can we see the arthroscopy picture as a bigger one?
So you want to make sure the syringe is exactly into the joint so that there is no soft tissue in between, is it?
Anything in between. Right. So because that can spoil my half an hour. I don't like it. So yeah, just the RF would be- just put your RF.
Graft is in now, is it?
No, sir, I have not put the graph here.
Still negotiating slowly, yeah?
Oh, it was actually the cannula has come out slightly, so I have to.
Yeah.
Because here the hand position is changing. We don't have a hand holder in the cadaver, so we are. So because the hand position keeps changing and the space is lost, the cannula keeps coming out. RF on. Hand up, hand up. Leave it loose. Lift. Just clearing the soft tissue before the pass. RF maximum. All bottles is alive. Oh, that is why it's not burning. Come. Separate and bigger. This is.
Sir, Naresh here.
Put salt here.
Sir, what precautions do you take while delivering the graft?
The main thing is there's a soft tissue in between. Handle should be clear. That's why we do this now. This is a last bottle. Okay. It looks okay. Everything will go. So now I think we can see the cannula tip there. So I'll pass. So normally what I do is I hold it here in the center and then negotiate. Slow. Leave it loose slightly. Leave it loose. Loose. Yes. So that is a passage.
Okay, sir.
So I'll pass it now. Now.
Naresh,
Yes, sir.
are there any questions in the chat box?
Yes, sir.
Because
Two questions are there. I am about to ask.
Dinesh.
Two questions are there. I am about to ask, sir.
I mean, if you have time, please ask those questions so that we can answer all those.
Okay, sir. Right. I will go ahead. Sir, one question is there from Dr. Dinesh Chidambaram in the chat box. Any lead suture to pull the graft from the Nevaseer portal?
See, some people use it. I don't use it. You can use a Nevaseer because I would like to finish it as soon as possible because so I don't want too much of a play in between. What I did right now was basically pulling this. See, my double pulley is in action now. So see my double pulley, my graft is in place. My double pulley is pulling, and it is inside. So I don't want, normally some people do definitely use a thing, but I don't use it because I don't feel it is required as such. So that is a graft gone in, and it is sitting on that is a glenoid anchor, glenoid sutures. Now I've done the pulley, so you can see the pulley is tight now, and now I'll put half hitches on top of it.
Okay.
You can definitely use it, but I don't like it because I don't like any other leading switcher, because if the leading switcher goes, it's a problem. I would like to hold it and do it.
You pull the graft inside, or you rely upon the double pulley threads to push the graft inside? Or
no, I don't rely upon I push it. I never use the double pulley threads. The double pulley is utilized only after the graft is parked in, because I have had cases where if you put too much of a tension on the glenoid anchors, it will come off. It will definitely
One
come
of the
off.
downside is if you pull too much, you can cut through the graft.
Cutting through the graft, sir, can sometimes the anchor will not take too much of a load. It will come off.
Yes.
I
The
have
best is
two
push
metal
the graft slowly.
Yes, sir. Push it inside, park it where we want, and then pull the pulley.
Okay,
Pull
okay.
the pulley, then it traction on the graft or on the anchors is very less.
okay, how you push past the graft at the edge of the syringe? You can see the graft. You push with the fingers, and further, what you use any special instrument to push the graft?
No. You just push it with a grasper. We just use a grasper. A grasper.
Ayyappan.
Sir?
Ayyappan.
Sir?
If you can show the anterior part and the posterior part on the glenoid where your graft you are suturing now, that will be one good view which the viewers can have. Number one.
Sir.
Number two, your placement of anchors on the glenoid.
Sir.
It is a flashback question.
Sir.
Your point of choice on glenoid,
Sir.
what are they?
Sir, we want it as you should be superior, sir. And so the best of bone in the glenoid is near the coracoid base. So the first anchor, anterior anchor, should be at the coracoid base, and it should be just on the anterosuperior. The second is little maximum posterior on the superior surface. So we don't want too much posteriorly, because we want this to cover superior. The action is superior, so we wanted to this to function superiorly. These are 2 points.
Why you want your anterior anchor to be more closer to the coracoid insertion? Any particular reason?
The bone stock is better there. Bone stock is better there. So second, it gives a landmark so that we are not going too much anteriorly.
That is correct. Base of coracoid process will have very good bone stock normally. Around the base of coracoid process. Yeah.
So in line with the coracoid, you'll put your first anchor, correct?
Yes, sir. Just behind the coracoid, we do.
Yeah.
So now the graft is here, sir. Graft, you can see the graft in position. Release that.
Yes.
You have tied the knots on the glenoid side, is it?
Yeah, it is done and finished. So glenoid. So now I'm going to this is the anteriorly separately kept anchors. That means I made 2 separate passes in the graft so that I can knot it. So that's what I'm doing now.
Sliding knot you can put, is it?
No, sir. So I don't normally put a sliding. I always like control. So I would definitely not, because too much of traction, too much of disturbance inside. No. So I put half hitches. See, you're gonna.
Ayyappan sir.
Naresh.
Sir. Sir, is there any role of acromioplasty along with the SCR? Is it good, or you have to do in all the cases of doing SCR, or is it only for selected cases?
No, acromioplasty, see earlier when we started doing it, Dr. Mihata said all cases acromioplasty. Now we know the acromion, if you take too much of acromion, there will be superior migration. If you are spacer, so we don't want too much of superior migration. So
Right.
we do acromioplasty, taking out any spurs which is there. But otherwise, and so that we also need a working space. See, in this particular cadaver, I found it very difficult because the space is very less.
Okay.
I found
Sir,
it.
your views on distal clavicle resection as well in
No.
case of doing SCR?
Why should be this? We need not do it, but whenever see there is a associated, if you want to do a Mumford, you can do it if there is a AC joint problem as such, but otherwise no. So idea is we are focusing on the cuff, and we should take out any spurs or anything which is going to abrade on the graft. That's all we should do.
Okay.
Okay, now that you have put the half hitches, and what do you plan to do with the two four stitches through the middle row? What's your plan further?
I'll show you.
Okay.
Who is this speaking? You know, quite interesting question. So, what's a good name?
I am Dr. Hari from Trivandrum, SP Fort.
Okay. Hi, Hari.
Nice going. I'm watching all through. Good.
Dr. Ayappan, there is an appreciation from Dr. Banerjee.
Sir.
He's not able to connect, so he has said, congratulations to you for a wonderful demonstration of a complex surgery.
Thank you, sir. All of you seniors have been very, very nice to me, sir. Thank you so much for coming and joining me on this. I really appreciate all of you being there. It's a great encouragement.
Ayappan,
Sir?
Don't call us seniors. We are your age only.
Oh, sir.
My heart.
Change.
Okay, don't make us feel so old. Okay, thank you.
Oh, sir. Okay, all of you, sir. Okay, have been people.
Rajkumar, he is telling in a different angle. Okay, he is telling that his respect is high on you. That's what he is telling.
Thank you, thank you.
Okay. So this last step would be here after finishing the anchors here, the anchors are in place. So sutures are in place, all good, great. Then next, here I've taken too much of this thing of the cuff out to visualize. But what I would like to do is, here in this particular step, I would take these sutures, the blue sutures which are here, the posterior, I will pass them through this cuff here and then come out. So that this cuff will, infraspinatus come and sit here. So suture, scorpion cuff. We'll try that.
Can you show the outside picture little big and find out which is your infraspinatus suture, which is your subscap suture that you are going to use? Ayappan.
Sir, 2 minutes, sir.
Yeah, okay.
Sir. So, sir, I am just what I'm doing right now is one second. So I am just removing this anterior ones. This is the anterior middle row, marked in blue. So then this is the posterior middle row. So here, what I would like to do right now is I'm taking this and I'm going to take a bite with a scorpion, or sometimes so you can do this infraspinatus area.
Ayappan, this is a hypothetical question to you. Okay.
Sir.
Imagine you are not able to get your anterior and posterior sutures through the cuff.
Sir.
Okay.
Sir.
Will the results of your SCR be compromised, or will it be on par with suturing of the cuff?
Sir, what will happen is if we are not able to get past the same through the anterior posterior, we can do separate side to side. So that will give results. So this is actually, I modified this. So in the actual description, okay, so what is given is this step is complete and finished. The glenoid is over, the middle side is over. Now soil lock or the lateral row and finished. That's it. So here what I have modified is I'm taking the same sutures and passing through the infraspinatus and taking bites. So if you're not able to do that, we can do a direct side to side with a spinal needle.
No, correct. Now the cuff is not accessible for you to take those sutures. Will the
Right.
results of your SCR be compromised?
Absolutely, sir. It will be compromised because horizontal stability is affected. There'll be more failure rates, definitely. So side to side repair is a must, sir.
So to get that side to side repair on your cuff, do you do some releases before you plan your SCR, or
Yes,
once
sir.
you're done with your graft, then you try looking for your cuff?
No, I would have kept everything ready. Normally the infraspinatus would have been here. I have to nibble out quite a bit. The tissue is not great. So otherwise my cuff would be in a normal rotator cuff. It's a irreparable cuff. I would debride it, keep it ready. Everything would be nice so that great. It would be perfect for graft passage.
So actually that brings another question now.
Sir.
Because if for example, if there are not much tissue in the infraspinatus, we should not be doing this SCR at all, isn't it? Yeah.
Yes, sir. It should be at least
Some tissue should be there.
Infraspinatus not being there means a posterior superior defect. Posterior superior means okay, we have to go in for a muscle transfer, lower trip transfer.
Yes, because in fact, it's for audience. I have to tell it's a contraindication to do SCR if there is no infraspinatus left over.
Yes, it should be at least a repairable infraspinatus. Yes, sir.
Yes.
What we could.
You have taken the bites from the medial row, already the half sutures. After that, you take the individual bites through the infraspinatus.
Yes, I'll again pass it once the middle row is done through the graft. I'll take the same sutures again through the infraspinatus because that is where your integration has to happen. So this is I have modified because I felt and because the entire construct it's so beautiful that you can't even make out there is no defect. You come out so beautifully, and the integration is so good. And if you're especially looking at graft and all that, so then you are definitely looking at all this.
So when you take these 4 sutures, there will be 4 green sutures that will be together in a lateral row swell lock, is it?
Yes.
Or and what you do with the rest 2 bites you have taken already in the anterior? You do it separately, or you join those 2 blacks anterior with the green sutures from the anterior?
I will incorporate that. I will incorporate that.
So all anterior 4 will come into a lateral row, and all posterior 4 will come into another lateral row, is it?
No, you have to crisscross.
Crisscross. Okay. Okay. Okay, switch it over. Withdraw slightly. Okay. Right. Right. Suck. Right. Then anterior. Anterior elbow. We'll take it out. ಬೇಡ ಅದು ಸ್ವಿಚ್ ಆನ್ ಮಾಡ್ಬೇಕಲ್ಲ. Ayyappan, thanks for the excellent presentation. I am just signing off. I will just get back to you conveniently. Okay.
Sure, definitely.
Thank you. Thank you. Yes. Thank you.
Right. Okay. ಚೆನ್ನಾಗಲ್ಲ ಮುಗೀತು ಅದು ಕಡೆ ತಗೋಣ this and blue ತಗೋಣ okay soil lock
Sir, Ayyappan sir.
yeah
Is-
Naresh
Is long head of biceps tenodesis can be done along with this SCR procedure?
yes definitely you can but normally what we do is we have our own we have developed our technique where we do call it as a hybrid SCR. What we do is we cut the long head of biceps in its groove, incorporate that in the anterior middle row anchor. So along with what we did now in this anterior middle row, what we do is we pass through the biceps. Tenodesis there,
Okay.
reverse tenodesis, like a biceps SCR. We combine a biceps SCR with a fasciolata. So if you are planning to cut out the biceps, why not use it in graft incorporation? So it will increase the thickness of the graft, helps in the mechanics. So it has got a natural supply. So definitely I will use it as a additional biceps SCR in the front anchor.
Yes.
So I'm just coming up with the lateral row now. Here the lateral row, what I've taken is, this is the posterior threads, posterior middle row threads, which I've taken, pass through the cuff, remnant cuff, and this anterior white. So here I'll be putting it.
And the plan is to do 2 knotless anchors laterally, is it?
Yes, sir. Two. That is a suture bridge type.
Yeah.
Cobra. Yes. Okay. Anterior.
Can you see the arthroscopy picture bigger?
Arthroscopy picture bigger, please. So here we can see the graph nicely covering the superior edge of the footprint, sir.
Yeah, we want to see the inside picture. Yeah, okay.
Yes.
Can go a little slow on the punching of the holes because
Yes, sir.
your anchors have to hold. That's why you can use it. Be little gentle there, and then you can get your sutures in. Yeah.
Yeah. So the bone is not at all good. It's cutting through. And not to tighten too much.
Yeah.
The bone is kind of cut through. Yeah. I'll just put it no problem. Hold it here. Cut through. Okay. Cut.
This is you are using Swive lock, huh?
Yes, Swive lock, sir. Swive lock is one advantage I find about a Swive lock is it takes features. We'll take all the 6. So that is one good. Right. Okay, leave. Right. Not like this, like this.
So totally there are 12 suture materials now, is it?
Sir?
Laterally, there are 12 suture materials or 6?
12 switches. 12 switches I would use, sir.
6 anteriorly, 6 posteriorly. Eh?
And maybe additionally one side to side also I might use.
Okay.
If I find there's some gapping is there, I would definitely use one side as well. So that is my anterior middle row and the posterior from here, the infraspinatus bite. Rotate more like this and hold up. Put up. Right.
Ayyappan,
Sir?
the average time that you take to do this procedure is how much?
It's around 2 hours, sir, because of the graft and all that. It normally depends upon the kind of, if the the field is good, around 1.5 hours, 1 hour 40 minutes. Yes.
Okay, it's 2 hours. So in that 2 hours, any time in your practice you had that the tissues have swollen up so much that you had difficulty for access?
No, sir, never.
Never.
Why? Because there are two things which I do, sir. One, the anesthesia. So it should be should be a very nice anesthesia. And second, I use a pump, always use a pump. And the pump pressure would be maximum 30. My pump pressure never increases above 30, 35. So that if the pump pressure is more, definitely it will bloat up. But never till we didn't have any cases till now where we didn't have to, we tried to bloat up and all that. The pump is I felt the pump and the thing is the key, sir.
Thank you.
And sir, normally we work in team. Means my team would be fast. Okay, graft half as would be, and the preparation would be very fast. So
you are right, Ayyappan.
Yes, sir.
The captain of the team is as good as the members of his team.
Yes.
Okay. So
Yes, sir.
the credit should go to the wonderful team that you have developed around yourself to help you in this difficult procedure.
That's what I said. I got excellent seniors like you, sir, and I've got excellent juniors like Naresh, Pramod, Dilip, everybody. Okay, thanks. The other one is pulled off slightly, but that's okay with me. And so it is basically crisscrossed in this area. The foot, it is almost come to the footprint, and the coverage is pretty good. The only thing which is I'm not very happy with this because I could not get more bites in the infraspinatus. Normally I don't have to take out more. I would have got a nice space here. I would have a nice integration would have happened. Here I'm not able to take it because I will take out too much of tissue in the infraspinatus area. But otherwise, this is I'm quite happy with the way it is going. That is a graft sitting there here. But I would like to emphasize that the key is just not putting the graft in, but also the incorporation of the anterior and the posterior. If you're not able to incorporate, you will not get results and it will fail. So especially this posterior incorporation is the key. So I would spend time definitely in preparing it, keep it ready, passing it so that I get a nice graft. The cuff should come and sit like this, and there should not be no gapping at all. And sometimes that's what we should. I also believe that we should use all the tissues available to us. That's why I would use a biceps, this, all the cuff, all the three incorporated. Yes, sir. Sir, thank you so much, sir. I think we'll wind up. Sir, Subra, sir.
Thank you, Ayyappan. Actually demonstrated very nicely. Thank you very much.
Hemant, sir.
We went each step by step. You had a good planning, and getting the channels correctly was absolutely superb. Very impressive. Thank you.
Thank you so much, sir. And thank you again. Abdul, Arthrex, Ankur, entire team, especially my team, Naresh, Dilip, Pramod, Srijit, everybody. Thank you so much. Rajkumar, sir, thank you so much. Sir,
Ayyappan, one last question before we sign off.
Sir.
How much would be the economics of this procedure for the patient?
Economics would be, yes, sir, quite expensive. Because
no, there must be something that you must be doing so that it will help the patient as well.
I reduce the surgeon fee, sir, so that we can do the case.
That is what you tell them. Then we are okay to send the patients to you. No, nevertheless, your skill set is great. We would also like to know the economics because the patients keep asking us what would be the economics. So that is one aspect of doing a good surgery that you are doing. And congratulations to you and your team and the industry that has supported you in doing this cadaver for the first time in Bangalore, probably live like this. And congratulations from the Karnataka arthroscopy team, the Bangalore arthroscopy team that we represent, and we are very proud of the consultant that you are and the face of the Karnataka arthroscopy that you are, and we really are proud and we appreciate. Thank you so much.
Thank you so much, sir. Thanks a lot, sir. Thanks a lot. Sir.
Thank you. Thank you.
Thank
And
you,
we are
thank
signing
you.
off. Thank you so much. Bye.
Thank you.
Ayappan sir. One last question, sir. Ayappan sir.
Well done.
Sir, is a long head of biceps can be used as a substitute for infraspinatus if there is no posterior side to side repair?
No. Okay. So we can't use it as a substitute for infraspinatus. It will maximum. See, we can use it definitely in, for example, if it's a small defect, like it's like a V-shaped defect, and only the supraspinatus is deficient, we can definitely switch it and do it as a standalone SCR, biceps SCR. But we can't substitute for the infraspinatus. Yes.
Right, sir. Thank you very much, sir.
Thanks, bye. And before
Thank you.
Thank you, dear. Thank you very
Thank you,
much. and
Rajkumar
what a
sir.
wonderful,
Thank
what a
you.
wonderful session.
Okay, round of applause.
Thank you, sir. Thanks. Bye. Thank you.
Thank you, Sandeep sir.
Hello. Thanks, Gana, for coming. Thanks, bye. Thanks.
हेलो अच्छा मेरे को जरा वो सीपीएस का जो जिससे आप बात करते हैं ना जो उनसे देखता है क्योंकि हमारा एमओयू वहां पहुंच गया है तो वही उनको बात करना है कि आगे अभी क्या है
Ajit, you can. Thank you, sir. Ajit, you can sign off.